Okay, good morning, everyone. On behalf of the Grand Rounds Committee, I'm super excited to welcome Dr. Amaka Inyanya. I'll be doing her brief bio here. Dr. Inyanya is currently an attending nephrologist and assistant professor of medicine and epidemiology at University of Pennsylvania. She's also the director of health equity, anti-racism, and community engagement in the nephrology division. Dr. Inyanya completed her nephrology training and combined nephrology fellowship at Massachusetts General Hospital, Brigham and Women's Hospital, and residency in internal medicine at Brigham and Women's Hospital. She holds an undergraduate degree from Cornell University, medical degree from Meharry Medical College, and master's degree in public health from the Harvard T.H. Chan School of Public Health. Dr. Inyanya is a clinical investigator with research interests that center on palliative care, informed decision-making, and health equity among patients with chronic kidney disease and end-stage kidney disease. Her work has been supported by NIDDK, NIHMHD, and the American Society of Nephrology. She is also passionate about promoting diversity within academia, as well as pursuing educational and outreach opportunities through traditional and social media. And on a personal note, as we crossed paths many years ago in fellowship, I'm very excited to welcome here today. So thank you so much for joining us.
Thank you for that warm welcome. And it's so nice to come full circle, as you said, back when we were fellows and just trying to make it through. So it's my honor to be here today to talk about something that's so important and that's picked up a lot of not only national attention, but international attention as well. So here is my financial disclosure. But I also wanted to share my life disclosures. So one, I'm a Black nephrologist. I'm also a first generation Nigerian American. A lot of people, when speaking about this race and EGFR controversy, like to kind of bring up ancestry and West African ancestry and APOL1, which is one of the genes that can put somebody at risk for CKD. And I've actually been genotyped because it is endemic in where my family is from in Nigeria. I have a family history of kidney disease. I studied Black sociology in college. I actually wrote an honors thesis at Cornell University about racial segregation among Black students on campus. And then I also went on to receive my medical education from a historically Black college, Meharry Medical College, which is the first Black college in the South to grant degrees to Black physicians. And so this is really a journey for me and very personal, which is why I've been so outspoken about this topic. So objectives of this talk will be to first discuss structural racism and its impact on Black individuals in the United States. Then I'll move on to discuss the history of estimating glomerular filtration rate equations. We'll touch next on pitfalls of using race and estimating glomerular filtration rate equations. And lastly, I'll propose future approaches to defining kidney function without race. So I always like to begin my presentations with a clinical case to give you a bit more context into the discussion. So there was a 24-year-old female with a history of sickle cell anemia, pulmonary hypertension, cerebral aneurysms, and kidney failure on hemodialysis who was presenting with pain. Her physical examination was notable for her being quite hypertensive and hypoxic. And on physical exam, she was noted to be in moderate respiratory distress, and she had this bilateral lower extremity edema. Her lab showed that her hemoglobin was 4.8, which is below her baseline of about 6, and she was hyperkalemic. Her chest x-ray showed small bilateral pleural effusions, and so we assessed this patient to be having to have sickle cell pain crises and also uremic, and so we admitted her for blood transfusion, pain control, and dialysis treatments. A little bit about her social history, a little bit more. She didn't have any primary care clinicians and was kind of bouncing around between different cities in Pennsylvania, seeing different hematologists. And with that, she had a very unstable living environment. She didn't have a physical address, so she was kind of couch surfing between family members, friends, halfway homes. And lastly, she had a lot of social stress. In addition to not having a physical home, she was a single mother their father was in prison. And so she really had minimal social support. So I took a step back and looked at the chart, doing my regular chart biopsy, but did a little bit more of a deeper dive for patients who have high social needs, as she appeared to have. And I noted that she had been admitted 18 times in a year and a half period, all for the same diagnosis of sickle cell pain crisis. So as I was reading through her chart, looking at all of her progress notes, admission and discharge notes, a few words kept coming up over and over and over again in the chart, and I'll share those words with you. Poor insights, non-adherent, unlikely to be sickle cell pain, missed dialysis, poor compliance, over-medicated with pain meds, and lastly, discharge disposition, which is everybody knows is kind of the stamp that everybody has to receive on their discharge note, which was kind of comical given how frequent she had been admitted. Sometimes her admissions were separated only by a few days or weeks. And so questions to consider as we move on with the discussion is, what is the best treatment plan for this patient? And then secondly, does one already feel like they know this patient by reading about her previous admissions? Like what kind of biases are being formed as you're looking at all of the admission notes, social work notes, and looking at some of the pejorative words that I've shared with you? Have you started to form these biases even before you've met the patient? So we'll move on with the discussion as we think about that. Let's talk about structural racism. So structural racism, as defined by Nancy Krieger at Harvard University, refers to the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems, such as housing and education, and so on, that in turn reinforce discriminatory beliefs, values, and distribution of resources reflected in history, culture, and interconnected institutions. So essentially, structural racism is a system of hierarchical opportunity that is based on phenotypic appearance that unfairly disadvantages some and also unfairly advantages others, namely majority individuals in the United States. And so let's look at the impact of structural racism in this country. So this is from the US Census Bureau, and it shows really a median household income by race and Hispanic origin in this country. So you can see as of 2018, the median household income for Asian households was $87,000, for non-Hispanic whites, $71,000, for Hispanics, $51,000, and for Black individuals, $41,000. And on the right, we have a figure from Pew Research Center, which is a nonpartisan think tank that publishes on social demographic trends in the United States. And here we see median wealth, and wealth is defined as the total market value of all intangible and tangible assets minus all debts. So as of 2013, you can see that for a white household, the median wealth was 142,000 versus 11 for Black individuals and 14K for Hispanic individuals. And what's really notable here are these gray columns for both graphs that represent periods of recession. And specifically for Hispanic and Black individuals, their post-recession values don't rebound to their pre-recession values as quickly as other racial groups in this country, which is very notable given the economic times that we're in because of the pandemic. So education disparities, also from the Pew Research Center, you can see here the proportion of US adults aged 25 and older who have at least a bachelor's degree. As of 2016, 53% of Asians had a degree, 36% of whites had a degree, 23% of Blacks, and 15% for Hispanics. And so why am I showing you these trends? Notably, you can tell that these trends are not diverging, they don't intersect. And what I'm trying to show you are the impact of structural racism in this country that results in the inequitable distribution of resources and power that closely track along racial and ethnic lines. And so the social determinants of health are just that. And they're defined by the World Health Organization as the conditions in which people are born, grow, live, work, and age. I've showed you many of these trends. And the reason that I start my talk with this topic is that a lot of the controversy surrounding race and EGFR has centered on biological inherent differences between racial groups, when we really should be focused on the impact of structural racism and how that affects health outcomes for our patients. And so to kind of give you a wrap up of the clinical case that I presented, a multidisciplinary team that included social work, case management, and psychiatry were convened. Now, this may seem like it's intuitive, however, it had not been done effectively. In particular, psychiatry really added a lot to this patient's care. For patients who have chronic diseases from childhood, they have a lot of undiagnosed, unrecognized mood disorders, untreated symptoms. And so for her, she had a lot of anxiety and she really needed like an atypical antipsychotic to really help with her management. And we really had to do a cognitive shift and have her focus on, for instance, transplant, kidney transplant, something that had never been raised for her. And then lastly, what I wanted to say was that a lot of the clinicians and team members that were treating this patient referred to her as a frequent flyer and frequently blamed her for her frequent admissions, were very frustrated and annoyed. Just to say that, again, it's not the patient's fault. And looking at the trends that I showed you in structural racism, we need to be keeping that in mind, that she is a victim of that, and that powerful resources, such as the institution that I'm speaking at, we have the resources to support these patients. And so we should keep that in mind. Okay, so let's switch gears and talk about the history of EGFR equations. So what is actually glomerular filtration rate? So this is a shout out for all of the nephrologists in the group. But for those who are not nephrologists, let's kind of break this down and go back to pathophysiology in medical school. So the glomerulus is a collection of capillaries in the nephron, the basic unit of the kidney, and blood flows through the glomerulus from the afferent arteriole to the efferent arteriole, and the filtrate of the blood, the waste, collects into Bowman's capsule. And so one glomerulus plus one Bowman's capsule equals a renal corpuscle. And GFR is the total volume of filtrate among all renal corpuscles in both kidneys per minute. So you can imagine that assessing somebody's kidneys function or how well they're filtrating the blood is quite complicated. And so eGFR equations allow for the indirect assessment of GFR using endogenous filtration biomarkers that we all have, creatinine and cystatin C, namely, without the need for collecting urinary clearance measurements. There's also variables that are associated with these endogenous filtration markers that cannot be easily measured. So we think about things that affect the generation and tubular filtration and secretion of those biomarkers. And then there's also demographic and clinical variables that are associated with certain endogenous filtration markers that we have to be thinking about when assessing someone's kidney function. And so essentially, eGFR equations are multivariable linear regression models that basically relate observed GFR to observed serum concentrations of those endogenous filtration markers, while also accounting for the demographic and clinical variables that affect GFR, or filtration markers, I should say. And so we'll do a deep dive into the first eGFR study, the MDRD study that was led by Dr. Andrew Levy at Tufts Medical Center, and really look at what this study showed. And so the modification of diet in renal disease study was actually a prospective clinical trial that was focused on the effect of protein restriction on progression of chronic kidney disease. And everybody in that clinical trial had iothalamate measured, which is an exogenous filtration marker, which is also our gold standard of measuring GFR. Everyone in that study had that measured. And for this eGFR study, 1,600 or so individuals were selected from that population to look at these eGFR equation. And so stepwise multiple regression was used to determine a set of variables that together best predicted GFR. And the variables that were considered for possible inclusion were, as you can see here, weight, height, sex, ethnicity, which we now know is actually race, age, and a number of clinical variables. And so here is really why we have a race coefficient in eGFR. This is what the study showed, and other studies subsequent to this study also showed this. But we see racial differences in the relationship between serum creatinine and measured GFR. So on the x-axis, you have measured GFR, and on the y-axis, you have serum creatinine concentration. These dashed lines represent white individuals in the study, and the dark line represents Black individuals. So you can see here from this graph for both women and men, at any given measured GFR, Black individuals had higher serum creatinine compared to white individuals. And they thought that was, very interesting, the investigators. And so to facilitate clinical interpretation, the results were re-expressed in terms of regression coefficients that referred to change in geometric mean GFR that was associated with unit changes in the independent variable. So I'll draw your attention to equation 7. A number of equations were tested, as they typically are in studies like this, and we'll look at equation 7. And so you'll see here the multiplication factor for GFR based on the final variables that were selected that, again, together best jointly predicted GFR. So the 6 variables were serum creatinine concentration, age, serum urea nitrogen concentration, serum albumin, sex, and Black race. So you can see here that the Black race multiplication factor is 1.18, which again would place Black individuals having 18% higher eGFR compared to non-Black individuals. And so the MDRD equation study conclusions were like, this is a huge win. This is great for the field of nephrology. The equation could be easily implemented in clinical practice. It predicted GFR rather than creatinine clearance. We had been really relying on creatinine clearance based on the Cockcroft-Gault equation up until this study. It used a validated method for measuring GFR. Again, ialphalamate is an exogenous filtration marker that is our gold standard. Demographic data that can be put into the equation was already available in the medical chart. So very easy to report in the medical chart. So this was very exciting for the field. And notably, the authors did note that including a Black race, Black ethnicity race term was important at the time because renal disease was more prevalent among Black persons, which it still is to this day. And so they thought that this was actually a strength of the study. So if this was such a huge win for nephrology, why is this study being challenged? Why has this become so controversial at this time? Well, one, for this study in particular, there was a lack of racial diversity. So among the 1,600 or so patients that were enrolled, only 197 were Black, which was about 12% of the study population. However, this is the biggest challenge of the study, and that was the assumption of why they saw racial differences between Black and white individuals in terms of their serum creatinine level. And so they said, previous studies have shown that on average, Black persons have greater muscle mass than white persons. And to support this assertion, they referenced 3 small studies that had been published between the 1970s and 1990s, and I'll quickly summarize them for you. The first was a body composition within a pediatric population study, which included 240 children, where they found that Black children compared to white children had less body fat. The second study was a body chemical composition study of about 40 adults. And so compared to age and sex matched white individuals, Black individuals had higher levels of total body potassium and elemental calcium. And the last study was a study of 60 healthy hospital workers, where they found that Black individuals had higher serum creatine kinase compared to white individuals. So first of all, there have been no studies to actually confirm that Black individuals in general have more muscle mass or greater muscle mass than all of the racial groups, right? Not just white persons. And it actually, you can't directly measure muscle mass on any living individual. And that studies that have done this have done body composition studies or even use different forms of imaging to assess muscle mass for individuals. And again, there have been no studies, absolutely no studies that have proven that Black individuals, again, have more or greater muscle mass than white individuals. And so the evolution of eGFR equations are as follows. So I showed you the 6 variable equation, and then the authors published an abstract which narrowed those 6 variables to 4, age, sex, Black race, and serum creatinine. And that multiplication factor for Black race was 1.21. And then 10 years later, the CKD EPI study was published, which was a significantly larger cohort of patients, 12,000 or so. And what they did was pull multiple longitudinal and clinical trial studies, which featured individuals that had measured GFR. And they had measured GFR with different methods, iothalamate, iohexol. This CKD EPI study had more racial diversity, so 2,600 or so Black patients, and they still found a multiplication factor that was statistically significant, where the multiplication factor was 1.16. And then in 2012, Dr. Leslie Inker from Tufts Medical Center published a validated cystatin C using the CKD-EPI equation, and found that there was no significant differences between Black and white or Black and other racial groups in terms of cystatin C levels. And so there was no Black race coefficient. But when you combine creatinine and cystatin C, you did have significant differences, although less so than the other studies. And just to say that currently in the United States, there's a variety of institutions that are either using creatinine clearance, the 6-variable MDRD equation, the 4-variable equation, we use that at Penn, and the CKD-EPI equation, which actually the recommendation at the time and our international guidelines said to upgrade to CKD-EPI. So there's a lot of variability in terms of who is using what EGFR equation. So I do want to make a note of the performance of EGFR equations. I think that is largely missing from this controversy of race and EGFR. So I'll draw your attention to this statistic called a P30 over here. And P30 in this circumstance represents the proportion of EGFR values that fall within 30% of measured GFR. So if you look at the P30 for CKD-EPI, it's 84%, which means that it performs slightly better than the MDRD study of 80.6. And also notably, this is not 100, right? And so this just shows you that there are limitations to the accuracy of EGFR, and that is why we call it an estimate. And you can also see that as you move up the GFR spectrum, that the accuracy actually improves. But if you move down the GFR spectrum, where we make actually most of our clinical decisions of GFR of less than 60, that the accuracy actually decreases. So when we're talking about losing accuracy, if we remove the race coefficient, you really have to keep in mind exactly what you mean by accuracy, because it's not that accurate, especially when we're looking at a lot of the, where we're making clinical decisions on the GFR spectrum. And so with that being said, in epidemiological studies, they talk about population health and using population health statistics to apply to an individual. But what does that actually mean when we're thinking about the accuracy of EGFR and coming down to the individual level? So this was a beautiful perspective that was written by Dr. Greg Miller, who's a pathologist and also a member of the American Society of Nephrology and National Kidney Foundation Race and EGFR Task Force, that really lays this out nicely. And if you think about the confidence intervals around any estimate, for instance, if we were to use the CKD equation and we had this, in this red dot would represent an African-American individual and the green dot would represent a non-African-American individual, you can see the significant overlap of all of these EGFR values. So when I did my master's and you see something like this, you really have to question if there's a difference when you have that significant overlap of confidence intervals, and that the overlap of confidence intervals actually greatly surpasses the Black race coefficient when you're looking at the EGFR equation, the CKD EGFR equation. So what are the racial differences for, what are the reasons for the racial differences that have been seen when looking at EGFR creatinine equations? This is the million-dollar question, right? They saw it in the MDRD study, they saw it in the CKD-EPI study, they've seen it in subsequent studies as well, nationally. And so we know for a fact that creatinine is definitely related to muscle mass. We've discussed this. It's related to the excretion of this biomarker, as well as generation, tubular secretion, and extrarenal elimination, which we think may be driven by enzymatic and transport processes. And we also know that there's non-biological processes that affect creatinine. So namely, a very high meat intake diet can elevate someone's creatinine, as well as medications. When we think about classically Bactrim, which interferes with the secretion of creatinine and can elevate those levels. These are the things that we think about. Now, namely, none of these things were directly measured or accounted for in any of the EGFR equation studies. And so when we're thinking about population health, right, we're thinking about developing an equation that is representative of the population that we can then apply to the individual. Shouldn't we really be critically looking at the populations that were included in some of these large studies? So let's kind of dissect the CKD-EPI cohort a bit. So again, there were 12,000 individuals, 2,600 of those were Black patients, so 33% of the population, much higher racial diversity. However, 70% of those Black patients all came from one of the cohort studies, the African American Study of Kidney Disease and Hypertension study, which was actually a prospective clinical trial that was focused on the effect of blood pressure reduction and control on the progression of CKD. Everybody in this cohort was Black. And so let's take a look at the baseline characteristics for individuals from the African American Study of Kidney Disease and Hypertension. So this is a very busy slide, but I'll just kind of draw your attention to some key variables that I thought were interesting. One, if you look at the trial baseline, it started as a clinical trial, but then subsequently became a longitudinal cohort, you can see that up to 50% of the cohort had an income of less than 15,000, and 41% of the cohort baseline. And then 41,000 had not yet graduated high school. And so when we're thinking about the representation of individuals in these population health studies, this study was skewed towards impoverished African Americans. Now, if you look at US Census Bureau reports, there's actually a big report that was published in 2009, right around the time of the CKD EPI study, that looked at poverty in America. The proportion or percentage of Black households that were making this income is significantly lower in that than that U.S. Census Bureau report. And so, if we're skewing the population to impoverished individuals, we really have to think about how we're applying this to the entire Black population. And we wrote about this in December, this editorial in one of our renal journals, where we discussed that if we're really going to do a population health study, or even any research study, we should be thinking about the representation within racial groups, right? I've showed you some trends of that shows you the impact of structural racism. And instead of assuming that racial groups are monolithic or the same, we should be enrolling we should be enrolling patients and keeping income in mind, keeping education in mind, and doing that within racial groups, right? Because we know that the Human Genome Study that was published in 2003 showed that genetically we are more similar between racial groups than within. And so we know that structural racism can lead to disparate health outcomes. Why not diversify our clinical trials to reflect that? And so this was kind of a call to the research community, this editorial, to say that when we're thinking about the NIH enrollment tables and progress reports that we have to submit, that perhaps it would be helpful to actually note the income of those individuals, the education of these, the social demographic factors that we know, again, can affect outcomes. So specifically for EGFR, thinking about an impoverished individual, what kind of diet is that person eating? What type of occupation does that person have that would affect perhaps muscle mass, a day laborer of some sort? We all need to keep this in mind so we don't have unintended consequences down the road as we're seeing now. So it's a good segue to think about the consequences of using race and EGFR equations. So I'll start off again with a hypothetical case. I've granted all of you board certification in nephrology, and so you're now nephrologists, and you have this 55-year-old male with a history of hypertension, diabetes, hyperlipidemia, and CKD who's presenting to you in your initial outpatient clinic for nephrology consultation. He's not had a nephrologist in the past and is referred by his primary care physician, who told him that he has kidney failure. Very classic presentation in the renal clinic. His medical conditions are stable, and you note that his blood pressure, hemoglobin A1C, and lipids are all at goal. So you take a look at the chart, and you see indeed that he does have advanced chronic kidney disease. His creatinine is very elevated. And you see two EGFR values, one for someone who's Black and one for someone who's not Black. And you note that there's a 21% difference here in these values. So a few things run through your mind after you look at the labs and as you're talking to the patient. One, you look at the patient, you're really unsure of his racial identity. Like, you just really can't tell. The next thing is that based on our international guidelines, KDIGO guidelines, you're aware that a patient's glomerular filtration rate should be equal to or less than 20 to be eligible to gain waitlist time. And you also remember your medical student who was shadowing you a few weeks ago, asking you about the utility of race and EGFR equations. And so the question is, what are your next steps? What do you do in this situation? So I also want to talk about another topic that is largely left out of this controversy, which has really been focused on statistical accuracy of what happens when you remove the Black race coefficient, and that is implicit and explicit bias. So let's define implicit bias. This refers to the unconscious attitudes and stereotypes that we carry with us that impact how we act, make decisions, and view the world. We know that implicit bias is associated with physician and patient communication, adherence to recommendations, and follow-up care. And namely, Black individuals in the United States are disproportionately affected with implicit bias that leads to poor health outcomes. So something that's more prominent in the literature and press are maternal fetal outcomes among Black women, and how poor they are related to, and how that's associated with implicit bias among this group. I want to contrast that with explicit bias, which is conscious and controlled acts. And so here on the right, I want to show some aggregate scores from the implicit association test. This is a test that is widely available for anyone who wants to identify their unconscious biases. It was developed by Harvard researchers. You can easily Google it and find it online, and you can identify unconscious biases related to race, gender, religion, what have you. Now, these are aggregate scores that were compiled between 2002 and 2015. And you can see here, compared to Black Americans, that there's still a strong automatic preference for white Americans. And you can see the opposite for looking at an automatic preference for Black Americans compared to white Americans. So just to say that everybody who's taken this test in the United States, not just white or Black or Asian, there's still a slight automatic preference for white. So keeping that implicit bias in mind is very important. And so how does that affect how does that affect healthcare? And so any health equity researcher or expert will cite this study in their talk because there's not been that many research studies that have looked at this, but this was a study that was published not very long ago in 2016 that looked at racial bias and perceptions of pain. So this study was conducted at the University of Virginia among medical students. And so the researchers actually started with all medical students and then narrowed their subsequent analyses and publication to white medical students because of the findings. So it was first, second, and third medical students. And what they did was to poll these students with a 15-item survey, true and false, about biological differences between Black and white patients. So some of the items would say, Black people have thicker skin than white people, or Black people have less sensitive nerve endings. And approximately 50% of students held one false belief about biological differences. Just to let you know, the true answers to those questions were related to epidemiological outcomes. For instance, Black people have stroke more often than white individuals, which is true. And so participants were asked to read two mock cases about a Black and white patient, identical, presenting in pain. And then they were asked to estimate the pain of each patient and make a recommendation to treat the patient's pain. So you can see here on this figure that those who held high beliefs about false biological differences between Blacks and whites were more likely to rate that Black patient as having less pain than an identical white patient. And you actually saw a reverse association for those who had low beliefs. So it just really goes to show you how that implicit bias can actually affect assessment and then subsequent recommendations for medical decision making. And so what does that mean for nephrology? So one, clinicians are left to judge a patient's physical characteristics to determine which EGFR calculation to use. There's Black or non-Black. That is explicit bias. That is a conscious and controlled act. And then there's implicit bias. And it's really unclear how false beliefs regarding biological differences influences clinical care. So we've been taught for decades, right, that Black individuals have greater muscle mass than all other racial groups. So how does that affect decision-making? If you do a quick search on Google for muscular, you find athletic, brawny, powerful. What is that doing to your decision-making? If you're holding these false beliefs about Black individuals as a whole, how does that affect your dosing of your medications, your choice of medications, your timing of referrals? It's something to keep in mind, although it hasn't been proven in any research study. And so, the pitfalls of using race and EGFR equations are numerous, in particular because there's so many racial disparities that exist already in kidney care for Black individuals. So one, there's a delay in referral to nephrology specialty care, as well as a delay in referral for kidney transplant evaluation if we're assigning Black individuals having better kidney functioning, higher EGFR. And our current international guidelines actually have specific cut points as to when someone should be referred for nephrology. So in a GFR of less than 30, they do say GFR in the guidelines, by the way. But again, most people don't have access to exogenous filtration markers like iothalamate, so they'll use EGFR. And then here, the recommendation is to refer once the GFR is approaching 20, but they can gain waitlist time once that GFR is equal to or less than 20. And again, we know that Black individuals are more likely to start dialysis without seeing a nephrologist. That's been described for decades, as well as less likely to be referred and also receive a kidney transplant. There can be a delay in kidney failure care. Black individuals are more likely to receive in-center hemodialysis versus home dialysis, like a home hemo or home peritoneal dialysis. And Black individuals are also more likely to start dialysis with a catheter, which is Not ideal. We really like patients to start with a fistula or a graft. And we're again delaying our patients for learning about different modalities, as well as having surgical creation of a fistula or a graft, which typically needs 8 to 12 weeks to heal before it can be used. We can have improper dosing of pharmacologic treatments. If you're assigning patients a higher EGFR or better kidney function, they could have falsely high dosing of pharmacologic treatments. We don't have an accommodation for patients of mixed race and ethnicity. I recently spoke to a woman who was receiving care and on the transplant list. She was phenotypically Black. She identified as a Black woman, but had one white parent and one Black parent. And she was very well informed about this topic, which is why we were even speaking. And she asked her clinician, "Can I use my white side to get listed earlier for a kidney transplant?" And they let her do it. And she was well within her right because we don't have an accommodation for patients like her. We also have the lack of transparency with patients during shared decision making. So this is where most of my research sits. I was talking to a few in the beginning about how I do a lot of serious illness and treatment decision making research for patients with kidney disease, and not telling our parents that we're not telling our patients that we're using their race to determine a clinical pathway for them is a violation of one of the central principles of shared decision making, which is transparency. So we wanted to look at the impact of EGFR on race correction, on care delivery, wanted to look at this scientifically. So this was a collaboration that I was proud to be a part of. It was led by nephrologists at Brigham and Women's Hospital, Dr. Salman Ahmed, Dr. Malika Mendu. And we wanted to see how many Black patients with chronic kidney disease would be reclassified into a more severe stage of disease if there was no race correction. So they had already compiled a large registry of CKD patients. It had 57,000 or so patients, and it featured self-reported race, EGFR using the CKD epi equation, CKD stage as defined by KDIGO, and we excluded anyone that had received any type of transplant and only included patients that were between the ages of 22 and 99. And so the outcomes that we were interested in were this composite outcome of referral for kidney transplant evaluation or waitlist, as well as dialysis access placement. And so here is our table one, which is quite busy, but I'll just highlight a few things which may resonate because I showed you a lot of the socio-demographic trends at the beginning of this talk. But for our Black, Hispanic, and Native American patients in the study, they were more often Medicaid patients compared to white and Asian individuals. There were also Black individuals and Native American individuals were more likely or more frequently had advanced stages of kidney disease, stage 4 and 5. And Black, Hispanic, and Native American individuals also more frequently had diabetes and hypertension. And so what do we find? So 4% of the population's 2,200 or so Black individuals, we found that 33% of Black patients would change to a more severe stage of chronic kidney disease if you removed that Black race multiplication factor. So for instance, if we had 618 patients that had stage 3A CKD, or what we consider moderate CKD, 549 would then fall to stage 3B. And and then 167, if you remove the race coefficient, would fall to severe chronic kidney disease or stage 4, and 27 individuals would fall to stage 5 or end stage kidney disease, CKD, 27 individuals. And so, we also looked at that critical clinical cut point of an EGFR of equal to or less than 20. And 7% of Black patients had an EGFR, with the race correction, had an EGFR of equal to or less than 20. And of those, still a minority of those patients had a referral for kidney transplant evaluation, or waitlist status. If we remove the race coefficient or race correction, 3.1%, or 64 individuals would have an EGFR that went from above 20 to then having an EGFR of equal to or less than 20. And so we wanted to look at logistic regression to account for many of the baseline differences that I showed you in table 1. And so this was the logistic regression for the composite outcome of being referred, evaluated, or waitlisted for transplant for CKD patients. And we found some significant predictors when we looked at this. So one, older age, you were less likely to be referred for that outcome. If you were hypertensive, you were significantly more likely to be referred. And looking at the different racial groups, we found that with the race correction, Black individuals were actually more likely compared to white individuals to be referred for that outcome. But if you remove the race correction, none of those individuals were referred for the outcome, which was very interesting. And then if we look at the logistic regression for the outcome of dialysis access, we found again some significant predictors. So older age, you are less likely to have dialysis access for whatever reason. If you're a female, you're also less likely to have an referred for dialysis access placement. Higher EGFR or better kidney function, you are less likely, which makes sense. And we also did not find any statistically significant racial differences for dialysis access placement. So in conclusion, approximately 1/3 of Black individuals would be reclassified to a more severe stage of chronic kidney disease if there was no EGFR race correction. And that although we were likely not powered to see everything that we wanted to see, that it still has implications for timely CKD management, referral for kidney transplant, and dialysis access planning. So there's two takeaways from this study that was really notable for me. One, the fact that with the race correction, Black individuals were more likely than white individuals to be referred for any transplant outcome. And that is consistent with a lot of literature that has shown for multiple reasons, Black individuals progress more quickly to needing dialysis than other racial groups. The second notable thing was for the individuals that removed the race correction, the 64 individuals that would fall from an EGFR of greater than 20 to having one of equal to or less than, none of those individuals were referred for any of the transplant outcomes, which to me actually speaks to clinicians perhaps waiting for someone's EGFR to get that low to actually refer them. This is an observational study. We can't know for sure, but it does show that clinicians do rely on EGFR to make their clinical decisions. So what is the counter argument? And there's always a counter argument for every controversy. And that is if the race correction does more accurately predict kidney function and then we remove it, then Black patients may have overdiagnosis of CKD, receive treatments such as dialysis and kidney transplantation when not indicated, receive inappropriately low dosing of pharmacologic medications, lose access to crucial medications, or become ineligible to donate kidneys. So first of all, I'm clearly biased, but I believe that this counter argument is very weak. One, the premise of this counter argument is that Black individuals truly have different inherent kidney function than all other racial groups. That's number one, biggest flaw. The other flaw of this counter argument is that it proposes these outcomes that are negative, like we don't have other methods of assessing kidney function. So we have 24-hour urine collections of creatinine clearance. We have cystatin C available, the other endogenous filtration marker that does not have racial differences. And our actual international guidelines actually say that if you're unsure about a creatinine-based EGFR value, that you should confirm the kidney function with either cystatin C or 24-hour urine creatinine clearance. And so that is to me the biggest flaw of this argument. Now, let's say that, for instance, that Black individuals do have different inherent kidney function than all other racial groups. And we had to really think about what would happen if we removed this race correction. Well, we wrote an editorial in JAMA in December that was based on a study that kind of using NHANES did some estimates about what would happen if we removed the race correction, how many Black individuals would be affected. And we propose, based on that study by James Dio et al., is that if we remove the race correction, that up to 1 million Black individuals in the United States would have a new diagnosis of CKD, as opposed to several thousand having these outcomes here. If we, again, just act like we don't have any other way of confirming kidney function and that Black people actually have different kidney function than all other racial groups. So if we wanted to weigh the harms and the benefits of doing something like this, wouldn't we want to focus on identifying and preventing kidney disease in the population that has the highest risk of poor outcomes, whether it be quick progression or higher mortality, higher hospitalizations, et cetera? Wouldn't we want to intervene earlier for those patients and really think about other methods of kidney function ascertainment for these other health outcomes? So I would encourage everyone to read the initial study by James Dio and others, as well as the editorial that we wrote about this. So in 2019, I and some colleagues at the University of Pennsylvania, Dr. Peter Reese and Dr. Peter Wang, wrote a JAMA perspective where we really called out the use of race in EGFR equations. We said race should be used to guide clinical care only if it meets the following criteria. The use confers substantial benefit. The benefit cannot be achieved through other feasible approaches. Patients who reject race categorization are accommodated fairly, and the use of race is transparent. And race and EGFR actually fail these criteria. So future directions. I should have started off this talk by saying that I'm a proud member of the National Kidney Foundation and American Society joint task force that's focused on the use of race and EGFR. It was convened in August of last year, and the charge was really to do a deep dive of the literature and to come forth and to push forth recommendations on how we use race and EGFR. Everything that I've said in this talk is not a reflection of any deliberations or discussions that we've had on the task force, but really my review of the literature and my opinion. I can say that in March of this year, the leaders at the National Kidney Foundation and American Society of Nephrology, so the presidents, actually published this statement that we would no longer use the race modifier. So this will change. And it's the task force that will release these recommendations soon about how exactly we do that is accurate, inclusive, and standardized in every laboratory. So that is forthcoming, and I'm really excited about it. So future approaches to defining kidney function without race. Again, these recommendations were made with my opinions and the literature that I reviewed. We need rigorous research to investigate previously accepted notions of racial differences in creatinine-based EGFR equations. So why did we see those differences? What was underlying that? Was it because the population was skewed towards poverty? Was it something else that we weren't accounting for, in particular, the effects of structural racism? We really need to go back and do it all over again, essentially. And there are also international studies, in particular in West Africa, where we do not see these differences. They've also done these studies in Europe. And so why are we seeing that in the United States is something that I'm really very interested in. We need to investigate the environmental effects of stress and discrimination, in particular on kidney function. There have been 2 studies that have looked at how stress and discrimination are associated with lower EGFR, so worse kidney function. I think it would also be nice to look at these effects on measured GFR to really assess how that affects our kidney function and perhaps racial disparities within that. We need to use alternative EGFR equations. I've said this throughout the whole talk. Cystatin C is the way to go. There are no racial differences there. It's just as good as creatinine or other measures of kidney function that do not use race, namely creatinine clearance, if you really need to confirm someone's kidney function. I know that this is ongoing research, that there's novel filtration markers that are being looked at that perform just as well as cystatin and creatinine, cystatin C and creatinine, but do not rely on race. And they're likely a bit far from clinical use, but it's already been published and you can definitely read about that. And we also need to have transparency in discussing EGFR determination with our patients. When you talk to patients who find out that this has been done behind their backs, they feel very betrayed. And so I think we should be getting into the practice of being transparent with our patients about what we're doing. So to wrap up the clinical case that I propose, you asked your patient about his race and he reports that he identifies as Black. You engage in shared decision-making with your patients about race, the limitations of EGFR, and indications for kidney transplant evaluation referral. You both decide to use cystatin C to confirm his kidney function, and it returns as 19, and you refer him then for kidney transplant evaluation, which anybody, whether it be UNOS or KDIGO, says that you can do. So in summary, structural racism contributes to disparate health outcomes among racial and ethnic minorities in the United States, not inherent biological differences. I want to be very clear about that. The pitfalls of using race and EGFR equations include delays in access to specialty care for nephrology, implicit bias, and a lack of transparency when discussing treatment options for patients with CKD. And while research is ongoing to develop these novel filtration markers, we should use alternative EGFR equations without race, urinary creatinine clearance, or direct measurement of GFR if you have that available to inform clinical decisions. So I will show my funding sources as well as my contact information, a shameless plug to follow me on Twitter, same name on Instagram, and I will take any questions.
Thank you, Dr. Inyanya. That was wonderful. Great presentation. I actually do follow you on Twitter.
Okay.
So I'll start. There's a couple of questions in the chat, and maybe more will follow. One from let's see, Dr. Okay, Wally put this question in. So I was also wondering about first choices of initial antihypertensives, calcium channel blocker or thiazides for Black patients, but ACE inhibitors or ARBs for non-Black patients.
Yeah, so again, this is me. I don't follow race-based medicine. I do everything at the individual level. So I know some colleagues who are very, very interested in this topic, especially in my division at Penn. There's Jordana Cohen, who's like a hypertension expert. And so stay tuned for that. But I think people are doing a deep dive into how that came about, as well as a number of other race-corrected algorithms in medicine.
Yep. I was wondering, so many of our academic medical centers sit in impoverished urban areas. And can you speculate on referral bias as part of how these results get generated?
Referral bias for the research study?
Yeah, in terms of the populations they care for. In other words, they're not broadly based community types of research.
I absolutely think that, and that's why I wrote that editorial. Looking at the CKD, the Black participants were highly impoverished, not representative of the US population at that time. And I think it's something that all researchers should be mindful of when you're doing your recruitment. You have to be mindful of it, and you have to track the social demographic factors that, again, are significantly associated with some of the poor health outcomes and could lead to differences between the racial groups. We can no longer just use race in itself to represent these differences.
Yep, thank you.
Mhm.
Another interesting observation and question from Dr. Wellens. He says, thank you for this powerful talk. Our lab reports creatinine to 2 decimal places. I suspect this makes our learners more twitchy than they need to be, and I'm not certain it is clinically significant. Do you feel that a creatinine of 1.29 is clinically significantly different than one of 1.34, both round to 1.3?
I don't, and a lot of people, this has been discussed widely, especially on the Twitter journal clubs for nephrology, is that we don't even know why it's reported to the second digit. But also, I think it's important to note that we shouldn't be going off of one. I think there's a huge margin of error, even around creatinine, that we should be looking at trends. And that is more important to me than a hard cut point of what is this person's kidney function now. But looking at trends in kidney function and really looking at that range to me is more clinically relevant.
Sure. Another question from Dr. Mark Parker, one of our senior outstanding nephrologists here at Maine Medical Center, who happens to have trained at Tufts and I believe knows Dr. Levy quite well. He says, excellent presentation, Dr. Inyanya, thank you. Would a better overall solution simply be a more straightforward measure of GFR? Why has cystatin C never gained traction?
Yeah, so I think this is the $1 million question. Cystatin C right now is not widely available. I've spoken to the National Kidney Foundation, which is really focused a lot on lab standardization across the country. It's just not, and it should be. It absolutely should be. It also is expensive. I mean, significantly more expensive than creatinine. It's also based on how many your institution orders, et cetera, and what the contract is with those like Roche and other companies that analyze cystatin C, but it's or produce cystatin C, but it should be more widely available. Now, when you say straightforward measure of GFR, I think the exogenous filtration markers that we use, as you know, a lot of people don't even like doing 24-hour urine collection. So then to do urinary clearance and iothalamate, I think that would be really, really hard to do for a lot of patients. But we have, again, another filtration marker that's cystatin C. Many institutions, I already know of one that has moved forward with getting that in-house, UCSF. But again, the task force recommendations are forthcoming. And so I think a lot of institutions are waiting so they don't have to do multiple changes in a short time period.
Great. Let's see, another question from Dr. Erickson that I think you just more or less answered. Question from Dr. Sharp, one of our preventive medicine fellows. What about the ASCVD risk score? I've heard that the decision was based off researcher designated race instead of patient self-described.
Yeah, so I'm not sure. I'll be honest with you. I can't say I'm an expert in all of the race corrected algorithms. But one, I think that's an important note that when you're doing research, it should always be self-reported race. And patients feel weird when you ask them that question, like, "What's your race?" But you should absolutely do it. It makes a difference. And I do know a group that is doing a deep dive into that risk score. In fact, I pretty much know groups that are doing deep dives into every risk score that was published in that New England Journal review last summer that described all of these race corrections, or the majority of them. So people are looking very closely into this. And I think that, again, if these risk scores or the use of race either widens or further marginalizes populations, we should not use them.
Yep, great. Not seeing any more questions. Again, thank you very much for bringing this talk to us. I think you're working in a very fertile area that needs a lot more attention, and looking forward to your future work. So thank you again, Dr. Inyanya.
Thank you so much for having me. And if you have any questions that pop up, feel free to email me. Thank you.
Fantastic. Take care. Bye.
Bye.